There is this incredibly relatable, almost universally human feeling of making the exact same mistake over and over again.
Oh, definitely. We've all been there.
Right. And to kick off this deep dive, I want to share a concept from a poem by Portia Nelson that captures this perfectly. It's this short autobiography about walking down a street and falling into a deep hole in the sidewalk.
I think I know the one you mean.
Yeah. So in chapter 1, you fall in, you're lost, you're helpless, and it takes forever to get out. Then in chapter 2, you walk down the exact same street, pretend you don't see the hole, and, well, you fall in again.
Naturally.
Right. And by chapter 3, you actually see the hole, but you fall in anyway out of pure habit. Chapter 4, you finally just walk around it.
In chapter 5.
Chapter 5, you walk down a completely different street.
That is just, it perfectly illustrates that incredibly frustrating progression we all go through. Moving from blind helplessness to conscious awareness of our bad patterns to finally actually changing our behavior.
Which is the hardest part. And that is the core mission of our deep dive today. We are looking at how we actually learn to walk down a different street when we're stuck in a hole.
Exactly. Exploring the honestly massive array of psychological treatments available to you, the listener.
Right. And to tackle this, we're going to set up a specific dynamic today.
Right.
I am going to put on my eager student hat, and you, my friend, are going to take on the role of the lecturer. You're going to guide us through this material.
I love that. I am more than happy to accept the role of lecturer, but let's keep it conversational, right? Because the mechanics behind how these treatments actually rewrite the brain are far too interesting for some dry, boring lecture.
Deal. So today's syllabus is drawn from section 16.2 of chapter 16 from Psychology 2E. Professor, as we look at all these different ropes we can use to climb out of the sidewalk hole, how do we even categorize them?
Well, the textbook divides the landscape of treatment into two primary camps. On one side, you have psychotherapy.
Okay, the talk therapy.
Right, exactly. These are the psychological treatments using behavioral, cognitive, or psychoanalytic methods to, help you overcome problems or achieve personal growth.
And the other side?
On the other side, we have biomedical therapy. This focuses on the physical hardware of the brain itself. It utilizes psychotropic medications and medical procedures to treat disorders by directly altering neural chemistry.
Wow. Okay, so since that opening poem mentioned falling into the hole out of, habit, it makes me wonder where these deeply ingrained habits and fears come from in the first place. Why do we keep walking toward the trap even when we know it's there?
That question takes us directly to the historical roots of modern therapy, which is Sigmund Freud and psychoanalysis.
Oh, Freud, of course.
Right. Developed in the early 20th century, this was really the first formal psychotherapy. Freud's central thesis was that most of our psychological problems, like the habits we can't break, the anxieties we can't explain, they're actually surface-level symptoms.
Symptoms of what, exactly?
For repressed impulses and traumas experienced in childhood.
Oh, so this is where the classic pop culture image of therapy comes from, right?
Yeah.
Like lying on a couch, staring at the ceiling, talking about your mother.
Exactly. If you look at the historical photos in section 16.2, there's this image, figure 16.9, of Freud's actual consulting room. It features this heavy, ornate, rug-covered couch.
I've seen pictures of that. It looks surprisingly comfortable.
It does, but the couch wasn't just for comfort. It had a mechanical purpose. Freud would sit behind the patient, completely out of their line of sight.
Wait, really? Why?
Well, by removing his facial expressions and his reactions from the equation, the patient felt less inhibited. The goal was to bypass the conscious mind's filters using techniques like free association.
Free association. Is that where you just, say whatever pops into your head?
Exactly. The patient relaxes and says literally whatever comes to mind, no matter how trivial or embarrassing it feels.
Okay, let's unpack this. If I'm just sitting there saying whatever pops into my head, aren't there certain things my brain desperately wants to keep hidden? I mean, it feels like the brain would have a bouncer at the door of the unconscious, refusing to let certain painful memories into the VIP section.
That is an excellent way to conceptualize it. Freud actually called that bouncer resistance.
Resistance, okay.
Yeah, so during free association, when a patient approaches a deeply buried, painful conflict, that mental bouncer steps in. The patient might suddenly go blank or change the subject or suddenly find a reason to miss their next appointment.
Oh, wow. So they just actively avoid it without realizing it.
Right. They demonstrate resistance to recalling those thoughts. And the psychoanalyst's job is to spot that resistance, to notice what the patient isn't saying and help them work through it.
That sounds like it would take forever.
It does. Because it's such a delicate process of sneaking past the bouncer, it typically takes years of multiple sessions a week. And over that extended time, a fascinating psychological mechanism occurs, which Freud called transference.
Transference. Okay, so if I'm spending years on this couch, unloading my deepest vulnerabilities to a completely neutral listener, I'm guessing I'd start projecting my own unresolved relationships onto them.
Precisely. You transfer the intense positive or negative emotions associated with other key figures in your life onto the psychoanalyst.
You have an example of that?
Yeah, the text provides a great example with a patient named Crystal. After years of therapy, Crystal begins to view her therapist not just as a doctor, but as a father figure.
Oh, I see.
She transfers her feelings about her own father onto the therapist, essentially attempting to extract the love, approval, or attention she missed out on during her actual childhood. The therapist then uses that real-time dynamic to help her process the original childhood wound.
That requires an incredible amount of self-awareness and verbal articulation. But, playing the student here, I see a major flaw.
Let's hear it.
What if the patient doesn't have the vocabulary for that? What if the patient is like an 8-year-old? You can't put an 8-year-old on a rug-covered couch and ask them to freely associate about their existential dread.
You absolutely cannot, which is the genius behind play therapy. Children simply don't have the cognitive development to engage in complex verbal psychoanalysis, but they do have a universal language.
We're just playing.
Exactly. Play therapy leverages that natural process to help children resolve psychological difficulties. Figure 16.10 shows a classic setup, which is a sand tray therapy room. The child is given a sandbox and a massive collection of miniature toys. Dolls, animals, fences, monsters.
So instead of telling you about their trauma, they basically build a physical diorama of it.
You got it. Children use the grammar of play to communicate what they can't say with words. The therapist observes how the child interacts with these toys to understand the roots of their disturbed behavior.
Does the therapist join in or just watch?
It can operate in two ways, actually. Non-directive play therapy involves the therapist acting as a quiet observer while the child plays freely, revealing their internal world organically.
Okay, and the other way?
Directive play therapy is more structured. The therapist provides specific prompts, suggests topics, or even plays alongside the child to guide the processing of a specific event.
As fascinating as it is to dig through the sandbox or, psychoanalyze childhood wounds, it sounds incredibly exhausting.
It definitely can be.
Sometimes when you're stuck in a hole, you don't really care why you fell in. You don't care about the historical context of the hole. You just want to get out immediately.
And you've just articulated the exact frustration that birthed behavior therapy. Behaviorists looked at psychoanalysis and basically said, we're spending way too much time digging in the past.
They just ignore it.
They completely abandon the unconscious mind. They focus entirely on the present, employing proving principles of learning to change undesirable behaviors. Their fundamental belief is that dysfunctional behaviors, whether it's a phobia or a bad habit, are simply conditioned responses.
Meaning they were learned.
Right. And if a behavior can be learned, it can absolutely be unlearned.
So this is where we bring in Pavlov's dogs. We're talking about classical conditioning, right?
Yeah.
Associating a stimulus with an involuntary response.
Yes. Let's look at how this practically solves a problem without ever analyzing the unconscious. The text introduces Emmy. She's an 8-year-old who struggles with frequent bedwetting.
Oh, that's tough.
Yeah, she's terrified of going to sleepovers. Now, a psychoanalyst might spend months looking for a repressed conflict or a complex family dynamic, but a behavior therapist looks at it as a conditioning failure. So they introduce a liquid-sensitive bed pad hooked to an alarm.
Oh, wow. So the moment moisture hits the pad, an alarm goes off.
Right. Mechanically, what's happening? The alarm is an unconditioned stimulus that naturally produces the unconditioned response of waking up.
Okay, I follow.
By repeatedly pairing the alarm with the physical sensation of bladder tension, Emmy's brain wires those two things together. Soon, the bladder tension itself becomes the conditioned stimulus that wakes her up before any bedwetting even occurs.
That's amazing.
The behavior changes, she goes to her sleepover, and no one had to analyze her dreams to fix it.
Here's where it gets really interesting. It's almost like counter-conditioning is just overwriting a corrupted file on a hard drive. You have an old behavioral response causing glitches, so you program a new, stronger response to that exact same stimulus to overwrite the old code.
That is a phenomenal analogy. You are overwriting the code. And behavior therapists use two main counter-conditioning techniques to rewrite those files. The first is aversive conditioning.
Aversive, so making it unpleasant.
Exactly. This is when you use an unpleasant stimulus to stop an undesirable behavior.
Yeah.
You are intentionally pairing a bad habit with a negative physical consequence.
So if we look at addiction, how does that work in practice?
A prime example used for alcoholism is a drug called antabuse. When a person takes antabuse, it inhibits an enzyme that breaks down alcohol. So if they consume even a small amount of alcohol, they experience severe, immediate physical reactions.
Like what?
Intense nausea, heart palpitations, vomiting. You are literally hijacking the brain's reward pathway. By repeatedly pairing the taste and smell of alcohol with those awful side effects, the brain overwrites the association of alcohol with pleasure. It creates a powerful conditioned aversion.
Okay, that makes sense for stopping a bad habit by associating it with a negative feeling. But what about the reverse? What if I have an irrational fear and I need to associate the thing I'm terrified of with a positive, calm feeling?
That brings us to the second technique, which is exposure therapy. And the historical origins here are incredible. The mother of behavior therapy is widely considered to be Mary Cover Jones, who documented a breakthrough case in 1924 with a young boy named Peter.
What was Peter afraid of?
Peter was absolutely terrified of rabbits.
Rabbits. Okay. How do you cure a phobia in a child without just traumatizing them further by throwing a rabbit at them?
You do it systematically, using a principle called reciprocal inhibition. Simply put, the human nervous system cannot be relaxed and terrified at the exact same time. One state inhibits the other.
Right. That makes physiological sense.
So Jones capitalized on this by bringing Peter his favorite afternoon snack, which was cookies and milk. While Peter was eating and relaxed, she placed a caged rabbit on the far side of the room. Over a period of 2 months, day by day, she moved the rabbit closer.
Wow. And it worked.
Because the relaxation of eating the snack overpowered the distant fear of the rabbit, Peter's brain slowly overwrote the corrupted file. Eventually, he was able to sit and pet the rabbit in his lap while eating his cookies.
But he literally snacked his way out of a phobia. That is brilliant.
Isn't it? And 30 years later, psychiatrist Joseph Wolpe refined Jones's technique into what we now use globally, which is systematic desensitization.
How does that look for an adult?
Well, to illustrate, the text gives us Jayden. Jayden lands a fantastic new job on the 29th floor of a skyscraper, but he suffers from a debilitating fear of elevators.
Taking 29 flights of stairs in a suit every morning is definitely enough motivation to seek therapy.
Absolutely. So Jayden and his therapist map out what's called an anxiety hierarchy. It's a structured list of fears ranging from mild anxiety, like just standing in the lobby near the elevator doors, all the way up to panic-provoking scenarios, like being stuck in the elevator during a power outage.
Okay, so they have a list. Then what?
Once the hierarchy is built, the therapist teaches Jayden progressive muscle relaxation. He learns to consciously put his body into a deeply drowsy, physically calm state. Once he's completely relaxed, the therapist asks him to just imagine the lowest item on his hierarchy.
So he just visualizes it. What if his heart rate spikes?
If he feels anxious, he raises a finger. The therapist immediately stops the visualization, and they go right back to the muscle relaxation exercises. They don't move forward until Jayden can imagine the scenario without any physical anxiety response.
So they just inch their way up.
Systematically inch their way up the hierarchy. By the end, the new relaxed response has generalized to the real world, and he can ride the actual elevator to the 29th floor.
And what's wild is that today, we don't even have to rely on visualization. We have technology doing the heavy lifting. I noticed the textbook mentions virtual reality exposure therapy.
Oh, VR is a total game changer, especially for environments that are too expensive, dangerous, or impractical to recreate. A prime example is the virtual Iraq simulation used to treat combat veterans suffering from PTSD.
I've heard of that.
Yeah, the VR headset immerses them in a visually and auditorily accurate simulation of Middle Eastern cities or desert roads.
But why does that work? I mean, if I logically know I'm sitting in a therapist's office in Ohio, why does a screen cure my PTSD?
Because it exploits a loophole in brain anatomy. The visual and auditory cues are realistic enough to trigger the amygdala, the brain's fear center, so the anxiety response activates. But simultaneously, the prefrontal cortex, the logical part of the brain, registers that the physical body is safe in a chair. Over repeated VR exposures, that logical safety signal trains the amygdala to stop sounding the alarm. It extinguishes the panic response without ever putting the patient in actual danger.
Okay, student hat firmly back on for a second. This behaviorism stuff is incredibly effective. but it feels like it leaves out a massive piece of the human experience.
How so?
Well, we aren't just programmable hard drives or Pavlovian dogs reacting to alarms.
Right.
We have an active inner monologue. We
Oh.
interpret events. We tell ourselves stories about what things mean. How does therapy address the actual thoughts bouncing around in our heads?
That exact observation is what led Aaron Beck and Albert Ellis in the 1960s to pioneer cognitive therapy and cognitive behavioral therapy, or CBT.
Ah, CBT. Very popular.
They realized that behaviorism was missing the internal narrative. The revolutionary core idea of CBT is this: it is never the external situation that causes your emotional distress. It is entirely how you think about and interpret that situation.
So it's not the hole in the sidewalk that makes you miserable. It's the story you tell yourself about falling into it.
Precisely. Cognitive therapists aim to identify and correct what they call cognitive distortions. These are irrational, deeply ingrained errors in our thinking processes.
Can you give me an example?
Sure. Consider a college student named Ray who fails a single midterm exam in his Psych 101 class. The event is just a failed test. But Ray has a cognitive distortion called overgeneralization. His internal monologue tells him, I failed this test, which means I'm inherently stupid, which means I'll fail every class, which means I'm going to flunk out of college entirely.
Wow, that escalated so fast from one bad grade to absolute life ruin.
It did. And that escalation, that specific distortion, is what directly causes his depression and anxiety, not the test itself. CBT dismantles this using the ABC model: action, belief, consequence.
Action, belief, consequence.
Okay. When we look at how this plays out in real life, the ABC model breaks it down perfectly. The text uses a great scenario with two guys, John and Joe. They both go to the same party. They both ask for a phone number from someone they've been chatting with, and they both get rejected.
Ouch.
Right. That rejection is the action, or the activating event.
Same exact event. But I'm guessing they have very different Bs, their beliefs.
Completely different beliefs. John's internal monologue activates an all-or-nothing internalizing cognitive distortion. He tells himself, I was rejected because I'm a loser, I'm ugly, and no one will ever want me.
That's a dark spiral. So what's his C?
Because of that belief, the consequence is that John becomes deeply depressed and isolates himself, refusing to go to any more parties.
And what about Joe?
Joe's belief system externalizes the event. He thinks, they weren't into it. Maybe my breath smells like the garlic bread I just ate. His consequence. He grabs a mint, goes to a different party the next weekend, and meets someone new. Same activating event. Radically different emotional consequences based entirely on the cognitive interpretation.
You all definitely have a bit of John in us.
Yeah.
But I have to ask, does simply identifying these mental distortions on a whiteboard actually cure severe clinical issues? I mean, it almost sounds too neat and toddy for something as heavy as major depression or trauma.
It's natural to be skeptical of something that sounds so simple, but the empirical data is overwhelming. Hundreds of studies cited in the textbook confirm that CBT is highly effective. It successfully treats anxiety, eating disorders, and significantly decreases suicidal ideation in teenagers.
Really just from changing the thought process.
Yes. There's an incredibly telling quote in section 16.2 from a patient who suffered from severe episodes of depression. They noted that while psychodynamic therapy was interesting for gaining insight into their past, CBT was exponentially more useful for their actual survival.
That's powerful.
It is. CBT didn't force them to endlessly dwell on childhood trauma. It gave them a practical, present-focused toolkit to manage their moods in real time. By consciously changing their thoughts, they were literally forging new neural pathways.
Having a daily toolkit is incredibly empowering. But just to push back a little, CBT sounds very mechanical, like you have a logic error in your thinking process. Let's debug the code. Is there a psychological approach that views the individual as more than just a broken machine or a collection of faulty algorithms?
Yes, there is, and that brings us to the humanistic therapy movement, pioneered by Carl Rogers. Rogers fundamentally rejected the mechanical view.
Okay, so what was his angle?
The goal of humanistic therapy isn't to fix a broken machine. It's to help an individual achieve their inherent potential. It's about self-awareness and self-acceptance. In fact, Rogers made a very intentional structural change. He stopped referring to the people he treated as patients, because that word implies pathology and sickness.
What did he call them?
He started calling them clients.
Oh, that is a brilliant, subtle shift in power dynamics. It puts them on equal footing.
It completely changes the therapeutic environment. Rogerian or client-centered therapy is non-directive. The therapist is not an authority figure there to give advice, diagnose your distortions, or interpret your unconscious dreams.
So what do they do?
They act as a mirror, practicing active listening. They acknowledge, restate, and clarify what the client expresses. But the true engine of humanistic therapy is what Rogers called unconditional positive regard.
Meaning they don't judge you, no matter what you bring to the session.
Exactly. They offer absolute acceptance, genuineness, and empathy. The underlying mechanism here is profound. Rogers believed that many of our psychological issues stem from feeling judged or having conditional worth.
Like we're only good if we perform well.
Right. So by providing a radically safe, non-judgmental environment, the therapist allows the client's natural biological drive for self-actualization to take over. The client learns to accept themselves because they are finally being fully accepted by another human being.
So what does this all mean? We've gone from Freud's rug-covered couch to Emmy's bedwetting alarms, to identifying the ABCs of our thoughts, to Rogerian unconditional acceptance. If you are listening to this right now and you want to seek help, which of these therapies actually works the best?
What's fascinating here is that when researchers look at massive meta-analyses compiling data from thousands of studies, the answer is no single psychotherapeutic approach has been proven vastly superior to the others.
Wait, really? After a century of debate between all these different schools of thought, none of them wins.
None of them claims absolute victory. I mean, CBT is highly effective. Psychodynamic therapy is highly effective. But the research consistently reveals that regardless of whether your therapist is mapping your cognitive distortions or exploring your childhood, the single most critical factor determining success is the therapeutic alliance.
The therapeutic alliance,
Yep.
meaning the relationship between the person and the therapist.
Exactly. The human connection itself is the active ingredient. It is the bedrock of healing.
That's beautiful, honestly.
The American Psychological Association identifies 3 intersecting factors for successful treatment: the clinical expertise of the therapist, your own personal characteristics and values, and the use of evidence-based treatment. The textbook actually features a dig deeper section focusing specifically on evidence-based practice in psychology, or EBPP.
So what does evidence-based practice actually look like when you walk into an office?
Well, it involves compiling the best available research and creating standardized treatment manuals. Therapists are trained to follow these manuals step by step. The goal is to reduce variability, to ensure that if you go to a therapist in New York or a therapist in London for a specific phobia, you are getting a specific treatment protocol that scientific trials have proven to work.
But the obvious critique there is that I am not an average statistic derived from a group trial, right? I am a highly specific, complex individual. You can't just apply a standardized manual to a unique human life and expect it to work perfectly every time.
And that is exactly the tension in modern psychology, balancing the science of standardized treatments with the art of treating a unique individual.
Okay, so we've exhaustively covered the psychological therapies, the talk therapies, and behavioral rewiring, but we have to address the elephant in the room. Sometimes, no matter how empathetic the therapist is or how well you've debugged your cognitive distortions, the hole in the sidewalk is simply too deep. The biological gravity is too strong to climb out with words alone.
That brings us to the other main branch of the syllabus, which is biomedical therapies. Sometimes the hardware itself needs support. This involves prescribing psychotropic medications or using medical procedures to directly alter the central nervous system.
And it's usually paired with talk therapy, right?
Yes, it is crucial to note that clinical research overwhelmingly shows these biological treatments are most effective when used in combination with psychotherapy.
So we are talking about fundamentally altering the chemical landscape of the brain. How exactly do these medications do that?
They target neurotransmitters, which are the chemical messengers that neurons use to communicate. Let's look at SSRIs, which are commonly prescribed for depression. SSRI stands for Selective Serotonin Reuptake Inhibitor.
Okay, how does that work?
Normally, when a neuron releases serotonin into the synaptic gap to send a good mood signal, the brain has a sort of vacuum cleaner mechanism that sucks the leftover serotonin back up. That's called reuptake.
So an SSRI basically jams the vacuum cleaner.
Exactly. It acts like a cork in the reuptake pump. Because the serotonin can't be vacuumed back up, it lingers in the synaptic gap longer, interacting with the receptors more, which amplifies the signal and helps lift the depressive symptoms.
What about other conditions?
Other medications target different chemicals. Antipsychotics, used to treat the hallucinations and delusions of schizophrenia, work by blocking dopamine receptors. Mood stabilizers, like lithium, are used to treat bipolar disorder by smoothing out the extreme neurochemical peaks and valleys of mania and depression.
But to challenge the pharmaceutical narrative a bit,
Yeah.
these aren't just magic pills you pop to cure a disorder permanently, right? What are the biological costs?
That is a vital distinction to make. Psychotropic medications do not cure psychological disorders. They manage the symptoms so the individual can function in their daily life. And the side effects can be severe.
Like what kind of side effects?
The textbook notes that long-term use of older antipsychotic medications can lead to a permanent neurological condition called tardive dyskinesia. Because you're blocking dopamine, which is also responsible for motor control, patients can develop involuntary repetitive movements of the face, tongue, and limbs.
Oh, that's terrible.
And even common SSRIs can cause significant side effects like nausea, weight gain, or chronic drowsiness. It is always a complex risk-reward calculation overseen by a medical doctor.
Are chemical medications the only biomedical options available? What if someone is treatment resistant and the pills just don't work?
There are physical procedural interventions. The most well-known is electroconvulsive therapy, or ECT. This involves passing precisely calibrated electrical currents through the brain to induce a brief seizure.
Seizures? That sounds intense.
It is essentially the neurological equivalent of turning a frozen computer off and back on again. It causes a massive neurochemical reset. It is surprisingly effective. Actually, about 85% of people treated for severe, life-threatening depression improve.
Wow. But there must be a catch.
There is. Because the seizure can cause memory loss, it is strictly implemented as a last resort intervention.
Is there a way to hit that reset button without the memory loss?
Yes, science is advancing rapidly. There is a newer FDA-approved alternative called transcranial magnetic stimulation, or TMS.
Magnetic stimulation.
Instead of a global electrical shock, TMS uses focused magnetic fields to stimulate very specific nerve cells in the brain related to mood control. Because it doesn't induce a full brain seizure, it completely avoids the memory loss associated with ECT.
Stepping out of the student persona for a second to pull this all together. When you look at this entire landscape, from lying back on Freud's heavy rug-covered couch to unpack your childhood, to Emmy's behavioral bedwetting alarm, to the practical daily toolkit of CBT, all the way to physically jamming the brain's serotonin vacuum cleaners or resetting the hardware with magnetic fields. It is just staggering.
It really is an incredible spectrum of options.
There are incredibly diverse, scientifically proven ways to build a ladder out of that deep hole in the sidewalk. We do not have to just keep falling in.
We really don't. The tools are varied, they are powerful, and they are available. But reviewing all of this leaves us with a profound, almost philosophical question to consider.
Let's hear it.
If cognitive therapy proves that our thoughts can shape our physical reality, and biomedical therapy proves that a chemical shift or a magnetic pulse can completely rewrite those thoughts, which one is really in the driver's seat?
Oh, wow. The ultimate mind-body problem.
Exactly. As neuroscience gets better at mapping the exact physical location of our cognitive distortions in the brain, will we eventually just zap away our fears with targeted magnets and abandon talk therapy altogether?
That's a wild thought.
Right. Or is reducing human suffering to a purely mechanical process completely missing the point? Is that deeply human connection, the unconditional positive regard of another person sitting across from you, the one active ingredient of healing that science and technology can never fully replace?
That is a massive thought to mull over as we wrap up. Thank you for joining us on this deep dive. Keep looking for those new streets to walk down, and as always, keep questioning your own inner monologue.